And this is what I'm going to show you in the coming lecture. This is, I'll start with one of my cases. This is a 75-year-old female patient. She was the mother of one of the lab heads in one of the clinics I go to. And she presented with this proximal femoral fracture and proximal humeral fracture. And you will notice she presented on Jan 2016. This is on August 2016. You can see the proximal humerus is still untreated because she was contraindicated for general anesthesia. So we had to only to do the proximal femur. This was the lateral view of the proximal femur. And of course, you can see how thin the cortex is. So I used to use this one, the proximal femoral nail or cephalomedullary nail, 2016. I did this. And once we started her walking, after maybe 3 or 4 weeks, she fractured her tibia. And her daughter said, okay, no more surgeries. We're still 3 weeks off the hip surgery, so we're not going to do anything for the time being, so please wait. I said, okay, let's wait. We'll treat it conservatively. She was a very slim patient, and we brought the physiotherapy. We used the brace for the tibia, and I said it's going to go into valgus. They said it's okay, and this is 7 months later when we did the follow-up for the tibia fracture and the proximal humerus. We started the patient again to try to walk after 6 months of very slow walking and very weak walking, and this was the follow-up of the proximal femur. You see how much shortening happened for the fracture to heal because the bone is soft, so it seeks stability, so it keeps compressing, it keeps sliding. And then once she started walking, we got this fracture, a distal femoral fracture. So when we treat the hip fracture, we always think as surgeons, so I have a fracture, I want to fix it, okay? But we forget about other entities. So besides this, we need to improve the bone quality, so treat osteoporosis. Because we call this always a bone failure, not an implant failure. So you have to do a treatment of osteoporosis. So what are the available drugs? Now you know, we have the abaloparatide, the alendronate, calcitonin, not used anymore, denosumab, ibandrocare, raloxifene, not used anymore, residronate, romosozumab, teriparatide, and zoledronic acid. Okay, these are the available ones. Anti-resorptive include these ones, bisphosphonates, denosumab, and the anabolic include these ones, teriparatide and romosozumab. Selective estrogen receptor modulators, hormone replacement therapy, strontium ranulate, and calcitonin, they found that the risk outweighs the benefit. So in many of the guidelines, you will not find these 4 medications. They are in the sum of the guidelines, but mainly we use the 2 anti-resorptives and the 2 anabolics. These are the 4 mainly used for treatment of osteoporosis. Advances the abaloparatide. Unfortunately, it's not available in Egypt. It's a second recombinant human parathyroid hormone analog, Tymlos, and it's FDA approved since 2017, and it was approved in the EU by 2022. The other one was lasofoxifene, which is a Sermonix, one of the selective estrogen receptor modulators, but it was not approved by the FDA since 2005, so it went out of fashion. It's only approved in Europe. So let's start with the first group. These are the bisphosphonates, alendronate, which is Fosamax, Fosavance, residronate, Actonel, zoledronic acid. We usually use the Aclasta. Zometa is kept for the oncology doctors, and ibandrocare, which is 150. The only problem of ibandrocare once monthly is that it does not have any effect on the hip. So that's why the first line includes the alendronates, the residronates, and the zoledronates, but does not include the ibandrocare. And these act directly by stabilizing hydroxyapatite crystals on the bone surface, and they inhibit the osteoclast. So they are anti-resorption. They inhibit bone resorption. The bisphosphonates are indicated for postmenopausal or glucocorticoid induced. They have these side effects: osteonecrosis of the jaw, atypical femoral fractures, esophagitis, and gastric pain. And they are potent suppressors of bone turnover, what Dr. Muhammad Tag was talking about. Since I told you they slow down the formation as they slow down the resorption. So they slow down both. So if you give the patient this medication long enough, he will go into a phenomenon called frozen bone syndrome. So the metabolism stops completely. And this is probably the reason for the atypical femoral fractures. That's why patients on osteoporosis for a long time sustain a fracture. You are giving a medication to prevent the fracture. While the patient was on the medication, he sustained the fracture. This is due to probably frozen bone syndrome. Okay, Denosumab or Prolia, you all know it. It's a fully human monoclonal antibody. It binds to a rank ligand, okay, and decreases bone resorption by inhibiting osteoclastic activity. It decreases the risk of vertebral fractures by 68% and the non-vertebral fractures by 20%. So it is a good anti-resorptive medication. It's administered subcutaneously, 60 milligrams every 6 months. And it increases the BMD by 1 to 7%. And this is a good medication in one aspect, is that it is one of the medication that has the least side effects. And it is the only approved medications for patients with renal affection. I'll show you this in the guidelines in the last few slides. It was FDA approved since 2010. Forget about these four. We don't use them anymore. Still, they are used in some countries in Europe and in the States. I think some of them are still used, but we don't use them anymore. Teriparatide, we gave a lecture this morning about teriparatide. Remember, this is a parathyroid hormone analog. It's an anabolic. It's given subcutaneously 20 micrograms per day for 24 months. Romosozumab, we just spoke about it, and you know now how it works. And vitamin D analogs, what is this? Is this a drug for osteoporosis treatment? The alpha-calcidol? Yes. In the UK guidelines in 2020, it was published as one of the inhibitors of bone resorption. So don't forget that alpha-calcidol is one of the things considered in some of the guidelines as an anti-resorptive medication. Okay? Guidelines. For diagnosis, I showed you these guidelines this morning. DEXA, we spoke about this. T-score equal to or more than minus 2.5. FRAX, like we said, the fracture risk assessment tool, more than 3% for the hip and more than 20% major osteoporotic fracture risk in 10 years. And this is how the curve shows. And I showed you this morning. These are the guidelines for how to diagnose osteoporosis. We said that minus 2.5, but now they added minus 1 to minus 2.5 with a fragility fracture, proximal humerus, pelvis, or distal radius. And they said that low trauma spine fractures, hip fractures, we give an anti-osteoporotic medication regardless of the DEXA, of the BMD, of the T-score. We have to give an anti-osteoporotic medication. And the last one, when the FRAX is high. And to prevent, these are settled in the prevention: exercise, adequate calcium intake, adequate vitamin D, about 800 international units, stop smoking, reduce alcohol, and fall prevention. How do we do the fall prevention? We adapt the home for all people. And the exercise should be regular weight-bearing exercise, strength and balance training. How do we prevent falls? By adapting the home, like removing things that the patients may trip over, like small table, small mats that may slide the patient, the door steps that are higher than the level of the floor, because this all may let the patient fall. Bathroom, we should install handrails and put non-skid mats. المشايات اللي مش بتزحلق دي. It should be well lit all the time, and the stairs have to have a handrail for all people. So the treatment algorithm, the last part. I showed you this morning. This is the UK guidelines for the treatment of osteoporosis. If you have a low risk, you don't need to do anything, just calcium, vitamin D, depending on the patient's age. Intermediate risk, you will measure the BMD and then reassess later on. The high risk, we have to treat, and the very high risk, treat and consider referral. And this is written because in the UK and the USA, they refer to an endocrinologist, not an orthopedic surgeon. Okay? I showed you this morning. These are low-risk patients that you don't need to do anything. This is the high-risk patient, and this is the very high-risk patient that we spoke about in the lecture this morning. And you just saw this slide in the last lecture. I'll show you another algorithm for secondary fracture prevention. Let's say this patient has been on medication. If he has not been on medication before seeing you, you look at the patient's age, life expectancy, and fracture risk by FRAX. If there is nothing wrong about these, then give calcium vitamin D. If there is any of the risk factors, then you have to look at the creatinine clearance. If the creatinine clearance is not okay, then the only medication that is approved is the Denosumab, the Prolia. This is the only medication approved for renal affected patients. If the creatinine clearance is good, then bisphosphonates, alendronate are the first line of treatment. Okay. What about if the patient has been taking a medication for the last 2 years, taking an osteoporotic medication? If the osteoporotic medications, these are options for continuing. If he has been taking it for less than 2 years and it's an oral bisphosphonates, just continue on oral bisphosphonates. If he's not happy with the pills, you can give him an injection. Intravenous bisphosphonates, continue. Denosumab or Prolia, continue. Selective estrogen receptor modulators, give him a drug holiday and change the medication. Strontium ranulate, you switch to bisphosphonates. Teriparatide, continue. For maximum of 24 months, unless he's one of the high-risk patients that we spoke about this morning. If he's been taking the drug for 2 years or more, and the treatment has failed, then we have to change. If the treatment did not fail, just continue what you're giving. If it failed, oral bisphosphonates, you switch to IV bisphosphonates. If he is already on IV bisphosphonates, you switch to teriparatide. Denosumab, you switch to teriparatide. SERM, you switch to IV bisphosphonates. Strontium ranulate, switch to IV bisphosphonates. And teriparatide, as we said, you switch again for another 2 years of anti-resorptive treatment, so you switch to IV bisphosphonates. Okay? These are the online guidelines I showed you this morning. So my take-home message is risk assessment is done by FRAX or DEXA, scanning, prevention by exercise, calcium, vitamin D, stop smoking, fall prevention, and the treatment you have either bisphosphonates or denosumab as anti-resorptives or teriparatide and romosozumab as anabolics. Thank you so much.